My talk is actually going to be a very nice transition from what you heard from Dr. Suralia. I'm hoping today to focus on best practices for survivorship care and really thinking through interventions that have been shown to be effective for our hematopoietic stem cell transplant survivors. So just a general outline, I'd like to highlight the complexity of survivorship care in hematopoietic stem cell transplant recipients, given all the various domains that you just heard Dr. Shiralia speak about that have been impacted by stem cell transplant. We'll then focus on interventions to promote physical functioning that have been shown to be effective, as well as interventions focusing on mental functioning and a little bit on future directions in this context. So just to give us a sense here, one of the things that is important to highlight is that survivorship is really focusing on addressing all these domains that have been impacted by transplant, whether it's the physical late effects, the psychosocial late effect, some of the chronic conditions and chronic comorbidities related to transplant, cardiac comorbidities, pulmonary comorbidities, as well as thinking about the cognitive effects, cancer recurrence, and health promotion. All of these aspects are included in our context of thinking about survivorship care. And in fact, when we think about survivorship care, we think about various elements, including prevention of the recurrence of underlying cancers or new cancers or late effects. So prevention of late effects, such as cardiac late effects that we've heard about from Dr. Surali and others today. Surveillance for new problems, so identifying whether it's recurrent cancer or psychosocial or cardiac or other late effects. And really thinking about intervention, which is the piece that I'm going to try to focus a lot on today. How do we intervene to make these things better and to improve the overall lived experience of our patients and their families? And then the piece that often is actually left missing is coordination of care. It's really, really hard, as you can imagine, with the complexity of the survivorship needs of our patients to coordinate care across different specialists, the transplant team, as well as the primary care physicians. So the ideal model for survivorship care is this concept of a long-term follow-up survivorship clinic that's often multidisciplinary or transdisciplinary, where a patient who've gone through stem cell transplant can go and meet with specialists to address their particular needs. And often in a lot of our large transplant centers, these survivorship programs exist, where a patient can go meet with a dermatologist, an ophthalmologist, physical therapy and rehabilitation specialist, occupational therapy, to come up with a comprehensive survivorship care plan tailored to their particular needs. And for some patients, they need to see all of these specialties. For others, it's going to be directed towards their particular needs. However, we know that approximately 50% of transplant programs do have some sort of long-term follow-up clinics. And to be honest with you, most of them do not have all of these subspecialties or these services widely available. And so it's really hard to actually deliver survivorship care for our patients and families. And a huge part of that is just pure logistics. It's really hard to arrange a clinic where you have all these specialists with expertise in survivorship care coming to meet our patients and families to address the needs of our patients as they're dealing with their survivorship issues. For small and medium transplant centers, it's simply not logistically possible to have a survivorship clinic where you do not have the volume to actually have all these specialists be in one room. And you can imagine when a patient sees 4 or 5 or 6 different clinicians, there are also logistics in terms of thinking about coordination of care. The other piece that we deal with is lack of expertise, that transplant survivors do require specific understanding of complications related to transplant, particularly chronic graft versus host disease, which is a major complication, as you have heard, that causes the main cause of morbidity and mortality in our population. And the last barrier to high quality survivorship care, I would say, the sense of ownership over addressing the survivorship care needs of transplant recipients. Studies have shown that transplant clinicians like myself tend to struggle to actually involve primary care really early on in the care of our patients. We are focused on trying to address the needs of these patients as much as possible, stemming from a desire to really be the primary caretaker for these patients. So as a result, these patients are often isolated from their primary care physicians, who also have a lot of expertise to offer in providing care for these patients. Nonetheless, despite these complex needs, there have been a lot of interventions that have been really tested. I'm going to focus on physical functioning, given some of the big limitations to physical functioning that you've heard about from Dr. Suralia's lecture. And just to highlight the data on exercise interventions during stem cell transplant. I should note that most of our exercise interventions actually started before or during the stem cell transplant hospitalization, so acutely during transplant. And the majority of them have focused on that acute recovery period, up to 6 months post-transplant. We have very few interventions, they're starting to pop up now, but very few interventions that address the long-term survivors' needs of our transplant recipients. Most of interventions that have been tested have focused on both aerobic and muscle strengthening interventions, and they really widely, greatly from being supervised or partially supervised interventions to ones that are really variable in intensity as well. But there are numerous randomized clinical trials showing the benefit of exercise interventions, despite this heterogeneity in the type of interventions we see, as well as the level of supervision. And many of the outcomes that were measured include cardiorespiratory fitness, quality of life using some of the validated measures that we heard about, as well as fatigue symptoms. So just to give you a scoping review of the literature, we have seen consistent findings where exercise interventions show moderate positive effects on cardiorespiratory fitness, on lower extremity strength and muscle strengthening in general, as well as on global quality of life and fatigue symptoms. There is inconsistent evidence on the benefit of exercise for emotional well-being in transplant recipient. We should note a lot of these studies did have some methodological limitations, and when we do these scoping reviews, we're also including data from very different interventions. There are very consistent theme, however, that the more supervised, the more intense the physical exercise intervention, the more likely that you actually move these important outcomes. And as I noted earlier, there's a little bit of variability across the transplant trajectory where these interventions have been actually incorporated. And it's important for us to keep in mind that we need more data on long-term survivors. So we really do need physical exercise interventions in patients with chronic graft versus host disease. It is a major cause of disability in allogeneic stem cell transplant survivors. We know that these patients have reduced functional capacity. They have muscular and functional limitations depending on organs involved with chronic GVHD. We also know that chronic GVHD is an inflammatory disease, and there is growing robust literature on the effect of exercise in reducing inflammation. We heard about the concept or the construct of sarcopenic obesity that really impacts particularly our chronic GVHD population. And there's now a growing body of evidence regarding at least the preclinical theoretical model in thinking about the potential benefits of exercise in this population. And I hope this area will continue to grow over the next couple of years. Shifting gears to give us a sense of some of the interventions that are focusing on mental functioning. I would put those in 3 different buckets. The 2 buckets here that you see on the screen are mind and body and stress management interventions. The second one is cognitive behavioral therapy, or CBT. Again, multiple randomized studies, often focusing acutely in the acute transplant phase or the acute recovery phase. Mindfulness-based intervention typically includes some relaxation-guided imagery, as well as progressive muscle relaxation. Generally, the outcomes are favorable with small effects on anxiety, depression, and fatigue, with some improvement in quality of life, particularly in programs that focus more on coping. And generally speaking, with mindfulness-based interventions, we see smaller effect sizes, so smaller effect on outcomes compared to CBT interventions. Some of the notable limitations in the literature is poor adherence. We know that adherence to these interventions is critical to get these outcomes, which seems very, very intuitive, that patients who are more likely to engage with these interventions are much more likely to achieve positive outcomes. We should also note that both autologous and allogeneic stem cell transplant recipients are grouped collectively in many of these studies, and we know that there are different needs for autologous and allogeneic stem cell transplant recipients. When it comes to CBT, this is probably one of the few interventions that has been tested actually in long-term survivors, and I'm going to show you some of the data on that as well. There are definitely benefits for lowering distress and improvement in emotional function, as well as more sustained benefit in terms of quality of life. And again, we see a common theme, just like with exercise intervention. The more intense the intervention, the most likely that you actually will see an important impact on outcomes. Again, similar limitations in the literature, less generalizable populations for CBT, including mostly white participants in many of the studies, and including both autologous and allogeneic stem cell transplant recipients collectively. I think one of the questions that came up in the chat in the panel already is a question about palliative care. What is the role of palliative care in this population with very complex symptoms and a difficult recovery? This has been studied again in the acute transplant hospital stay setting. This is a conceptual model of this kind of intervention, the idea that palliative care has expertise in managing complex symptoms, helping patients cope with their illness, and managing their expectation about transplant and recovery. And often, I should say that clinicians, as well as patients and families, often misperceive palliative care as equal to end-of-life care. This is not the case in this model. This is really thinking about palliative care as a team of experts that can help patients live as well as possible, given the intensity of treatment that they're receiving. So in this conceptual framework, what we try to do is really integrate palliative care during the acute hospital stay for stem cell transplant, with the idea that perhaps palliative care can actually improve patient and caregiver outcomes acutely during transplant, and perhaps even improve sustained effects, both in terms of quality of life and psychological distress. This was a randomized study of 160 patients with blood cancers who have gone through stem cell transplant. They were randomized to receive palliative care that was integrated within their transplant care, where patients saw a palliative care clinician at least twice per week during their stem cell transplant hospitalization. Of note, the palliative care intervention only took place during the transplant hospital stay. So this was an acute transplant intervention during transplant hospitalization. And these patients did not see palliative care in outpatient palliative care follow-up clinic. The other half of patients were randomized to transplant care alone, which basically allowed palliative care consultation upon request. However, we knew this was not the standard of care for these patients. Patients were followed longitudinally and collected patient-reported outcomes, including some of the outcomes that Dr. Suralia spoke about. And we focused at week 2 during the transplant hospital stay, given that patients experienced the worst symptoms during that time. What we see here is that really the effect of the intervention on a wide variety of patient-reported outcomes, including quality of life, fatigue, symptom burden, depression, and anxiety symptoms during hospitalization, with really medium to large effect sizes with improvement in all of these outcomes during hospitalization. What was really interesting that these patients who experienced this improvement during hospitalization also had some sustained improvement at 6 months post-transplant, with a reduction in clinically significant depression and PTSD symptoms. So again, intervening acutely during the transplant hospital stay at least led to sustained psychological and mental functioning benefit up to 6 months post-transplant. I also want to highlight this one particular study, a cognitive behavioral therapy intervention focused on post-traumatic stress symptoms in our transplant survivors. This is one of the few studies that focus on later transplant survivors, 1 to 3 years post-transplant, and patients were randomized to a telephone-based intervention that was based on cognitive behavioral therapy versus usual care. The primary outcome was looking at post-traumatic stress here, comparing the control group to the usual care group, as you can see here, and CBT did really improve PTSD symptoms. It also led to a reasonable reduction in global distress and depression symptoms, as you can see here as well in the blue, highlighting the CBT group versus usual care. So again, we know we have effective interventions that can help our patients physically and emotionally. And I should take a moment and say, why do we care about mental functioning so much? Besides the fact that we probably do care because we do want our patients to obviously feel the best that they could after going through such a traumatic experience, such as stem cell transplant. But there are more and more robust data really demonstrating that mental health can have really strong impact on transplant outcomes, including survival, the risk of acute graft versus host disease, as well as healthcare utilization and length of stay in the hospital. This is just one of those studies highlighting the impact of depression in particular on these outcomes, but there are numerous other studies really showing the same pattern. So with that, just to speak about future directions, we know that physical medicine and rehabilitation probably will play an important role in our transplant recipients, and we need more robust data on interventions, specifically in long-term survivors, and also strategies to really tailor and enhance our physical exercise and recovery interventions to the needs of particular survivors. The need to focus on chronic GVHD, I hope I highlighted enough today, both from a physical and mental functioning perspective. And we also need to think about how to scale and enhance accessibility of these interventions, perhaps using digital therapeutics as well as other tools to reach more of our transplant survivors. And with that, I'm happy to end here and we'll take questions later. Thank you for listening.